So it is my pleasure to introduce Dr. Alexandra Tate and her talk, The Treatment Imperative, How Moral Language Shapes End-of-Life Care Decisions.
Thank you, Brian, for that lovely introduction. I'm thrilled to be here. Actually, one of the reasons I picked U Chicago as the place for my postdoc, I was deciding between a few places, was because it had the MacLean Center for Ethics, and I wanted a place where I could be a sociologist and exercise that muscle while also doing outcomes research. And if you're in the back, feel free. There's seats in the front. I know it's scary, but they're here. You won't be disrupting. I won't pay attention to you. Okay. All right, so let's get into it. So I'm actually navigating two screens here. That's why the technical difficulties are there, but hopefully we will move forward. I've experienced worse technical difficulties during talks. Okay, so no disclosures to report. So I'm going to set you all up with a paradox. So this is really the puzzle that motivated this line of research for me. So when we ask Americans how they want to die, the answer is remarkably consistent, right? It's at home, with family, or surrounded by loved ones or family, in comfort. But that's not what's really happening in practice. About 20% of cancer patients, for instance, die in hospitals, and nearly a third spend time in the ICU in their last month of life. And this isn't unique to cancer. Across all Medicare beneficiaries, about 1 in 5 dies in a hospital setting. And for some populations, like those with dementia, hospice enrollment rates are pretty low, just 12%. So the question that's motivating all of this work is, why is there such a gap between what people say they want and what actually happens in practice? Okay, but I wouldn't be a good sociologist if I didn't take you through some theory. And because this is an ethics talk, I think you will all indulge me and appreciate this. So I want to introduce 3 key concepts that inform my work and help us give us some useful frameworks to understand the social forces underlying these issues. Okay. So first is introducing the process of medicalization and its more recent counterpart, biomedicalization. So medicalization describes conditions that weren't previously seen as medical, and then they get redefined as health problems requiring medical intervention. And this happens as medicine advances, but also through patient advocacy. So people pushing to have their conditions recognized. Examples would be like Lyme disease or fibromyalgia. You could also think about conditions like ADHD or obesity as being medicalized conditions. At some point or another, they experience that process. Biomedicalization takes this definition further. So it's not just about treating disease as in medicalization, but it's about optimizing health through technology and risk management. That probably feels pretty familiar to you all here as just citizens, right? Not necessarily as clinicians. And critically, it shifts the responsibility for health management onto individuals. We see this through things like, preconception testing for people wanting to get pregnant, genetic testing, all these wearable devices. The Oura Ring is like literally everywhere now, although apparently it was like burning people, I think so. Preventative medications, right? These are all tools for managing health and mitigating risk before bad things happen. Other examples would be BRCA testing and intervention early, right, to address the risk. Egg freezing or using pharmacogenomics for personalized medicine. The list goes on is the point. So this expansion of medicine operates within a broader shift in how Americans think about morality itself. That's really the crux of my talk today. So I'm going to take you through an argument that philosophers have introduced called secular morality. And philosophers and Katz and Singer are among the first to have introduced this topic, and Rosen is another one. They argue that American morality has undergone a fundamental transformation. So we've moved from primarily religious frameworks for a morality that is more focused on health-based frameworks. So they argue that in the past, we've got moral judgments, in the past, being a good person, right, meant following religious teachings like belief in God, right, avoiding the 7 deadly sins, gluttony, adultery, etc. And not to suggest that those aren't still prevalent, but their argument is those are waning in favor of a new morality. They argue that today, being a good person or a good citizen increasingly means preserving your health, preserving your own health. And the big takeaway, and again, I don't know if you guys recognize Andrew Huberman, a neuroscientist from Stanford. He's got a podcast that's very heavily focused on health preservation. And I don't mean to call him out because I think that there's some, merit to his work. But if you listen to his guests and if you listen to him, a lot of the sort of framing of his recommendations has a moral valence to it. And then there's, of course, this book by David Sinclair, Lifespan, Why We Age and Why We Don't Have to. Again, there's, this implicit, or some would argue explicit, like, we've got to avoid aging. What can we do as individuals to do that? And this book takes you through a variety of things that you can do that. So the real takeaway here is that our health choices are becoming moral choices. They're now subject to judgment about whether we're being responsible or irresponsible. Okay. So the expansion of medicine, right, operates within a broader shift in how Americans think about morality itself. So these philosophers argue that American morality has undergone this transformation, right? We've moved from these primarily religious frameworks to these health-based morality frameworks. And again, in the past meant being, following religious teachings. Here we go. So under secular morality, I should say, certain health behaviors get coded as right or wrong, virtuous or not, right? So if you exercise, eat well, follow medical advice, you're seen as responsible and receive social approval. And I want to flag, like, these are theories. Like, I'm sure we can think of examples that counteract those theories. And I'm not here to, like, adjudicate, that. I think those are important, right? But this theory is a helpful framework for understanding part of the data I'm going to show later. So, but if the argument here too is if you smoke, if you're overweight, if you don't follow doctor's orders, you're cast as irresponsible. An interesting example I've come across recently is if you're obese and have, financial means, like, why wouldn't you take a GLP-1, right? And again, GLP-1s have a really, important role in health preservation, and many people are advocating for them. But at the same time, people who have failed on GLP-1s are reporting feelings of sort of this, like, moral judgment that, like, they couldn't hack it on the GLP-1, and now people are going to wonder why they're obese. So this is sort of an interesting new phenomenon I've been thinking about. So this all extends beyond lifestyle decisions, though, to treatment decisions. So being a good patient means doing what your doctor recommends. We're held accountable not just for our own behaviors, too, but for the health of people we care about. And this creates a cultural expectation that you'll pursue medical treatments if you're diagnosed with, let's say, cancer or another life-limiting chronic illness, because, why wouldn't you, right? Or, for some, these might be more delayed because of second opinions and blah, blah, blah. But generally speaking, people are held socially accountable, either implicitly or explicitly, for opting out of medical care when they have a medical problem. I just want to call out that like protein craze is a good example of some of this, right? If you actually look at the advertisements for, like, Khloe Kardashian's cloud protein infused popcorn, I thought I had seen it all. But then I saw this at the grocery store. It is not cheap. That the protein's everywhere now, like this protein craze. And I'm not here to say that, like, lots of protein is bad, but I think there's, like, this potential for overcorrection, like that protein is what you must be doing. And actually a lot of influencers on, like, subreddits for health and TikTok are really framing it this way. And again, my favorite, how not to age. All right. So this moral framework intersects with what scholars call the treatment imperative. And the primary scholars behind this theory are Sharon Kaufman and Janet Shim at UCSF, two of my favorite sociologists who informed a lot of my work. And they describe that the treatment imperative involves this inexorable momentum towards medical intervention in American healthcare. And they argue that, does this not work? Oh, it doesn't want to work. And they argue that this momentum can exist throughout all disease stages, much of the time for the better, right? That, like, it can save people's lives, it can mitigate symptoms. But in later stages of illness, particularly when illness becomes potentially terminal, it can be problematic in later stages. And they wrote a really wonderful paper about late life cardiac interventions if you're interested in this topic, you should definitely check out. They argue that it drives both doctors and patients to pursue treatment, even if it's inexpensive, they can't afford it, even when it's difficult, involves lots of burdens on their daily life, and involves substantial side effects. And they argue that our healthcare system is really structured, right? It's not necessarily the fault of clinicians, but it's really structured to reward cure-oriented interventions rather than comfort-focused care. And one of my favorite cartoons that I had to throw up, I love a cartoon in a talk, is Mr. Potato Head wanting to look like the Planters peanut guy. And so this is really just to underscore that, it's not just doctors, but it's like patients saying like, I want to look like this, or I want to be like this. Can you help me? Okay. So where does this momentum come from? So Shim, Russ, and Kaufman argue that there's a pathway that it follows. So they argue that medical innovation through like feasibility studies, pilot studies, eventually lead to larger scale clinical trials. Once promising results come about, payers will eventually reimburse if it is shown to be cost effective. And then once that happens, it becomes something that physicians must offer through a variety of mechanisms, right? That might be like, like ASCO, recommending that fertility preservation should happen right before chemo, for instance, but it nonetheless becomes standard of care eventually, and what physicians must or are suggested to offer. And then once it becomes standard of care and doctors recommend it over time, they argue that then it really becomes part of a patient's expectation. So they might actually go to the visit asking for this particular treatment and have knowledge about it, right? Because we have the democratization of health information largely through the internet. So these treatment imperatives operate within a larger changing landscape of medical authority. The pressures to pursue medically intensive care are not happening in a vacuum. And in fact, sociology, if I had to describe it in like one sentence, it's nothing happens in a vacuum, right? Like we don't take for granted anything. We don't take for granted any process or policy, historical movement. We have to understand like what led us to this moment. Why is this an expectation? And so, these theorists are all arguing that these pressures to pursue medically intensive care are happening because of these social forces over time. So we've moved from a paternalistic model where doctors decided decisions predominantly or much more paternalistically and top down to a shared decision-making model, which you're all familiar with, where patients are supposed to really be partners in the decision-making, though that can be to varying degrees, of course. At the same time, we now have sociologist Stefan Timmermans, and a mentor of mine at UCLA, calls the engaged patient, which is someone who researches their condition, asks questions, and participates actively in their own care. I threw up some screen grabs of TikToks, but this is really pervasive on TikToks and different subreddits of lay people, sometimes clinicians or experts, sort of sharing with patients across disease types, like this is how you can be your own advocate. So, you can, and Renee Anspach at Michigan has called this the internet health consumer. But we have to, we can't ignore the fact that clinicians still maintain what we in sociology call epistemic authority, or the ones with expert medical knowledge, right? Clinicians know better than patients because of all their training, what available treatments are out there, what the indications are, what the contraindications are, right? But patients know best about their own bodies, right? So there's this tension. But what's changed in the course of the last 50 years is that clinicians can't just tell patients what to do or just decide for patients without communicating, right? They now have to engage in some form of persuasion, particularly if a patient does not readily agree. So if a patient readily agrees, maybe there's no persuasion, but actually in other work that I've done, I see that even before a patient agrees or disagrees to treatment, the doctors engage in proactive persuasion to really push patients that like, this is the right thing. Instead of just saying, this is what I recommend, saying this, I recommend this because like it will do X, Y, and Z. And so they're doing that because they know that patients have, of course it's to inform patients, but it's part of shared decision making, right? You're telling patients what they need to know and what you recommend. But even when patients resist, and I'll show some examples, doctors continue to really persuade patients to accept treatment, and we'll look at the different ways that they do that. But this creates a tension where we are in this historical moment. How do we balance patient autonomy with the need for expert guidance, right? Like there's a reason patients walk into your clinic and ask for your help. It's because like they need your help for something. Like if they really could self-treat at home, they would do that. And sometimes they do, but they're entering the exam room because they need help. They need support of some kind. Okay. So this takes us to the final theory, and then we'll get to some data. You've been doing great. So this gentleman up here is Foucault. He's a philosopher and anthropologist, and he conceptualizes, he comes up with this concept called biopower. And he argues that power in modern medicine doesn't work through force. It's not, you can't force someone to take chemotherapy, for instance. He argues it works through cultural normalization. So making certain choices that patients are given feel, and to opt into something, feel more normal or more natural relative to other choices. So this is biopower in action. So cultural expectations take what could be a simple medical recommendation. I recommend oral chemotherapy, and transform it into something that feels like a moral imperative, something you should do, even if moral language isn't present. He argues that through this normalization process, patients come to internalize the idea that they're supposed to endure hardships for their health, that suffering through treatment is just what good patients do, right? If you're given a course of 6 cycles of chemotherapy, like you're supposed to, obviously communicate with your doctor about side effects, but you're supposed to finish that course. And returning to normal health isn't just a personal desire. Many people have that. But he argues that biopower operates at the population level, where healthy bodies mean, more cynically, productive workers and stable societies, right? If we have lots of healthy people who get back to health from being sick, like they can go back to work, they can continue whatever social projects they were engaged in, they can be a better parent, right? They can be more present with their friends, right? There are a variety and infinite ways that a return to health is not just an individual imperative, but it has social meaning too. And I just wanted to call out a book that I think points this out really beautifully, called Righteous Dope Fiend by Philippe Bourgeois. He's an anthropologist at UCLA if you're interested in like digging into more of the sort of how biopower plays out. So through biopower, through this normalization, decisions about treatment stop being, he argues, just medical decisions and become also moral obligations. Not treating becomes less thinkable. So this brings us to a specific puzzle in end-of-life care known as the hospice underutilization paradox, coined by Rigg and Spencer in their paper down there. It's super tiny, called The Political Economy of Hope. So research consistently shows that patients and families say they want comfort-focused care in later stages of illness, right? And we know that hospice is more widespread than ever. There's awareness, of hospice more than ever. Yet, interestingly, the average hospice enrollment is kind of hovering between 2 and 3 weeks before death, even though we know that folks decline mostly slowly over time. And there are improved but not perfect prognostic tools. And so I'm sure you can all think of examples where like prognosis is not perfect and like the hospice referral that you gave was like truly the best you could do, and that's fine. But like on like a population level, policymakers argue that we could be doing better. And this hasn't changed in a decade. And so that's the paradox. Like we have more awareness and acceptance than ever. Of course, people still don't accept it. Like we're gonna but there's more relative to before. There's more availability of hospice than ever. So why aren't we seeing more use of it? And that's the question that they ask. And how this link, and their argument, and I should have put in a bullet point here that underscores this, but their argument is that it's because of these forces that I described earlier, like these social changes. It's because we've got, increasing, focus on preventing bad things, increasing focus on prolonging life, wellness, anti-aging. It's like a whole industry now. This moral valence of pursuing treatment and also availability of technologies, right, more than ever. And they argue that that kind of gets in the way of some of this. And they actually did qualitative retrospective interviews of clinicians and patients and find that both patients and clinicians really are driving this, right, in at least these retrospective interviews. So I then started wondering, could the way we talk in medical encounters be contributing to this pattern that we're seeing? Okay. So we're out of theory. So we know these theoretical frameworks are relatively compelling and they're widely used in medical sociology, but they're not in the moment observations. I wanted to know if there really is a treatment imperative. How is it emerging in actual conversations between clinicians and patients? What are the specific things that people say and do that makes aggressive treatment feel natural and feel necessary? And how do doctors and, oops, I advanced in the wrong way. How do doctors and patients and families use language to construct treatment as not just reasonable, but morally right or with a moral valence? Okay, so a peek into the data before I get into the papers. So I analyzed 90 video recorded visits, outpatient visits between oncologists and patients between 2014 and 2017. I'm actually in the process of expanding that corpus more, obviously for more recent data and a more diverse data set through a cancer center grant. I just got very excited to get started on that. I used snowball sampling to recruit 5 oncologists from 3 different clinics. 3 of these specialized in gynecologic cancers, 2 in urologic cancers. The clinics were located in academic medical centers in the Western US, so I'm mindful that there's not good diversity of patients, although there were patients with a variety of health literacy levels, which was at least helpful there. And we then recruited patients using convenience sampling. So anyone willing to be recorded within these clinics, and that yielded 82 unique patients in the sample because some had multiple visits to the clinic. Of the 90 encounters, 51 involved a treatment recommendation for chemotherapy, radiation, or another modality that directly targeted the cancer. So I excluded any recommendation that was for just Zofran or just Benadryl, right? I really wanted to focus on decisions about treating the cancer itself. Okay. So I used conversation analysis as my method for these papers. So conversation analysis is a largely qualitative method. It came out of sociology in the 1950s with work from Irving Goffman and Harold Garfinkel, if you're familiar. It's not about counting frequencies, although it's increasingly becoming a quantitative tool. And actually, I co-authored a paper in 2016, Counting in Primary Care, the association between the frequencies of questions in primary care visits across 500 visits. At the end of the visit, if doctors say, do you have any other questions, or what questions do you have, or what other issues do you have, or some other, we looked at the difference between some versus any across these many visits. And then we correlated that with patient response to see. And we found that it was statistically significant. There was a statistically significant association between using some or what other questions do you have, and patients actually responding with an additional question or concern. But if you used any or any issues, or better yet, anything else, you would get more likely to get nothing. So if you want to speed up your visit, do that, but that's probably not a patient-centered care practice. So you can use quantitative CA as a quantitative tool, but it's been largely used as a qualitative tool. So, and in these papers, they're qualitative. So we examine the video data. We video record the data first, obviously captured with consent. We later transcribe the data. The transcripts, if you've ever read a CA paper, they include notations that tell us how stuff was said, right? Because what was said is important, but how was said is meaningful, right? If you've ever been in an argument with your significant other, you know this, right? It's how it's said that matters, not just what is said. So these transcripts include notations for emphasis, pauses, intonation, nonverbal gestures like eye rolling or like a big, right? Like that's not captured usually in a transcript, standard transcript. These are all things that give meaning to building relationships and to interactional projects beyond just words. So the method focuses on actual communication behaviors as they happen and what consequences they have by looking at the back and forth, what we call turn taking. So, see, the originalists of CA, said that we are looking at the turn taking machinery. Like in this case, I'm looking at the machinery of a decision. Like, so if the doctor recommends something, we then look at how the patient responds, or maybe they don't respond. And then we look at what the doctor next says. And then we look at what the patient or the family member says next. And we just look at the back and forth to see how is affiliation built? How does a decision get made? What are the hangups? What are the holdups? How does conflict start? And I used a software known as Elon out of the Max Planck Institute to systematically code the video for qualitative patterns in how treatment decisions unfold. Okay, so why would we even use conversation analysis? It's the equivalent of a sociological microscope. So it lets us see things that are really invisible at larger scale, right? There's lots of quantitative data sets we see. We might see the outcome of a given treatment over large swaths of data, but we don't actually know how that decision got made or how it didn't get made, right? Maybe a decision to treat didn't get made and the patient refused treatment, but we don't know why or the machinery of that. It's not just on what, but how and when something was said. Like the timing matters too. I actually wrote a paper on the timing of a diagnosis. It happened after the doctor recommended treatment. And so the doctor presumed the patient had understood her diagnosis. It was revealed almost 40 minutes later that the patient did not understand her diagnosis, so did not understand why post BSO surgery, why chemotherapy was still recommended. And so she finally asked the doctor, do I have cancer? Do I not have cancer? After a ton of conflict. And the doctor says, I don't know. There could be microscopic cells left behind the naked eye cannot see, which is why I'm recommending chemotherapy and radiation. And so, that's where the understanding happens, but it's not for like so much time. And like already the conflict has been built up by then. And the patient leaves without accepting treatment. She doesn't decline it, but it was a single case study underscoring that like, this is how conflict can start, right? The order of things matter. Again, CA gives us access to real-time decision-making. It is not reliant on retrospective accounts, which we know are good. Like I interview people, it's a good method, but not the best historians of our own behavior. And it reveals small taken for granted practices that turn out to potentially have major consequences. And just as a caveat before I move forward is that as sociologists, our primary job is to identify patterns and help us understand their consequences. But I'm not here to prescribe like what ought to happen, like what you ought to do in your practice, what you ought to not do. I'm here to tell you, if you do X, this could happen, Y, or this is how, we're understanding it. And then it's up to clinicians to really run with that and understand what the real clinical implications are, and, medical ethicists and things like that. So I just want to sort of pull back a little bit and say like, I'm not here to tell you exactly what's right and wrong to be doing. Okay, findings. So taking you through a few papers, let me do a time check. Okay, we're good. So I'll start with my first paper, which looked more broadly at how doctors advocate for treatment in cancer care. And in this paper, I found that oncologists used surprisingly strong persuasive strategies to encourage treatment, even when patients were in a stage 4 of disease. So what does that mean? Well, specifically when patients showed any hesitation or resistance to the recommended treatment, sometimes explicit, like just asking a bunch of questions or saying nothing at all and delaying acceptance, to overt resistance, like I don't want to do that, or why am I doing that, or like that I'm tending toward not doing it. Direct quote from my data. I saw two main patterns. So first is that physicians explicitly used moral language. So if you want to see, like, by the way, I'm doing an overview of several papers. If you actually want to see the full data excerpts, they're in these papers. So feel very free to look at them. So the first practice was that physicians used explicitly moral language. So phrases like, this is the right thing to do, or I'd want to be around for my own kids. You and I are the same age. Like, I would want to do this therapy. These are all, any quote you see is a direct quote from my data. So second, they did what I call invoking death. And interestingly, this came out of saying, like, I was surprised that doctors mentioned death at all, because all the sociology and public health literature say doctors never talk about death in visits. And this paper is kind of saying, well, they do, like, but it's in the service of persuading patients to accept treatment. So that's not totally correct that they don't talk about it. It's just a certain context, they might avoid it more. So examples would be, these side effects are better than the alternative, responding to a patient who is saying she doesn't necessarily know if she can keep going with the chemotherapy. Or another example, if we don't do chemo, this will come back. And if it comes back, it will be deadly. Now, to be clear, cancer without treatment is often deadly. So physicians aren't wrong here. I'm not here to say that they're wrong at all. But what's sociologically interesting to me is that they invoke death as a persuasive tool, specifically when patients resist, rather than, say, providing survival statistics or discussing quality of life or quantity of life or what happens on the other side when, like, they get through the treatment. So I thought that the choice to use death as a specific lever was notable here. And in fact, I counted 13 death invocations compared to only 4 invocations of statistics or survival data. And this pattern suggests just something about how persuasion works in these higher stakes environments, right? And this notably can create a kind of tension between honoring clinical expertise, right? Making sure that your patient's very clear on, what happens if they don't want to do this, and honoring patient autonomy and shared decision making. Okay, so let me give you more specifics about what this looked like in advanced disease. So in my second paper, I examined 14 encounters involving patients with stage 4 disease where a treatment decision was being made. So in one of these visits, hospice was mentioned. I'm not, obviously this is a convenient sample, so I'm not trying to make a case about how that was rare. Like, it just happened in one case. What's notable, though, is that it was embedded in a list alongside 3 other off-textbook interventions. And I followed this oncologist throughout his day in the hallways and everything. And before he went in, he was really stressed out because he knew it was going to be a hospice conversation. He said to me, like, this is going to be a really tough conversation. I got to bring up hospice, like nothing else is working. And he was really nervous, and he actually kind of delayed going into the room a little bit. It was just because he was very close with this patient. So in the video, I then expected it to be just a hospice conversation. And part of it was a hospice conversation. But the first half of the visit was focused on 3 additional treatment modalities that he entered the room explaining that could be next directions for the patient. Like, he was very clear what he's on is currently not working, that he is stage 4, but then he said, okay, we've got a few additional options though. Like, we've got this off textbook modality. I mean, he was clear that they were off textbook, but they were more, medically intensive treatment. And then he brought up hospice as the 4th option. And so this paper really argues that, like, when you embed it in other off textbook treatments, like, it's possible the patient's going to go for that and delay or forego the hospice option, like, because if you, the expert, are recommending it, it might carry some weight. So in the other 13 cases, further medically aggressive treatment like chemotherapy, radiation, or hormone suppression, or a combination of those, were recommended as an additional step. And what's striking is that none of these encounters, well, I should say first that these treatments were explicitly endorsed as reasonable, good, or worth trying, which again might signal to the patient, like, well, I'm going to try it then. I mean, they're obviously free to opt out, but that gets challenging when the expert in front of you who you've built a relationship with is endorsing something. What's striking though is that no of the encounters in this data involved a clear prognostic discussion about life expectancy or quality of life trade-offs with additional treatment. And again, like these are cross sections. Like this is a cross sectional data set. It's possible that in a visit before or after or in a MyChart message, like that was communicated. So I don't want to suggest that didn't happen, but arguably at the moment of a new recommendation being introduced, the quality of life trade-offs, you know, are recommended to be shared with patients when you do that in the policy literature. Okay, so oops. So this got me thinking, if this is all happening in late stage disease, what's happening right at the beginning when patients first opt into treatment? So I went back to look at early stage treatment discussions, and this is a paper that came out last year with my co-author, Tanya Stivers at UCLA. So what I found was that from the very first treatment discussion, the very first time a newly diagnosed patient hears about treatment options, moral language is common. And I identified three main practices that construct treatment as a moral obligation. And so really the goal of this paper was not really to count the ends. I'm just doing this so you have some understanding of how many in the of the 51 treatment encounters were sort of brand new patients with moral language being used. But really more importantly is we created a typology of different types of moral language. Like how can you actually code for moral language in visits? So first is the way that recommendations are designed. So using words like we really need to do this, or we should do this, or we must do this, or this is reasonable. These carry moral weight. So second would be presupposing compliance, talking about treatment as if it's already been decided before the patient actually agreed. This was so interesting to see, by the way. Like I thought this was the most interesting finding. And this is really persuasive because it makes treatment the default path. And then declining requires actively disrupting the conversational flow on behalf of the patient. And arguably, you need a pretty empowered patient to be like, wait, like, hold on, like, I didn't agree yet, right? I didn't see that in my data. I saw every single encounter that involved this, patients went along with the treatment and there was no like explicit, like you sign off. It was like, okay, so we'll sign you up for radiation or like, we'll move on to the next step. And then finally, when patients hesitate, physicians use persuasion that minimizes the burden of treatment. So an exact quote from the data, when a patient says that she's tending towards not doing chemotherapy, the response by the clinician is 18 weeks is much less than dying from a recurrence in 3 to 4 years. And that's probably true, right? But the argument also at the same time is that this reframes patient concerns about suffering as trivial compared to the alternative, making continued resistance seem potentially like irrational, right? And what he doesn't do is talk about like, that, he doesn't focus on other persuasive mechanisms like statistics or likelihood of coming out on the other side, or more importantly, he does not talk about symptom management because later on in this particular visit, she reveals she's just really worried about the symptoms. She's really worried about the side effects of chemotherapy, and then it's addressed. But by that point, he's already set up that he's already responded in a morally sort of charged way, and she does get frustrated, and it doesn't help that the daughter also is really pushing her towards treatment, and so she's sort of feeling pushed on both sides. And as a behavioral scientist, we know, and this is relevant for politics, like if someone has a particular feeling or presupposition or preconception, like the more we tell them that what they're doing or how they're believing is not right or potentially flawed, they're going to dig their heels in. Like to bring them around to our side takes a lot more artful skill. That skill is it's a soft skill. It's not always learned in medical practice. And by the way, you only have 15 minutes with a patient. So like, this is not like an easy fix, right? I'm clear on the challenges here. Okay. So as I alluded to before with this, the daughter who was in the room, The patients and families are also reflecting this. They're using this moral language too, saying things like, an example from my data, when a patient was in the middle, diagnosed with treatment, she says, treat it as aggressively as you need to now. I'll be as sick as I need to now. And she actually had stage 3 ovarian cancer, but she was very sort of adamant that whatever she needed to go through, she would. But we know that cancer treatment, signing up for it, is not a one-time decision. We might think of it that way, but it's actually months of ongoing adherence, right? So every time you come back for an infusion, every time you take an oral chemo drug, every time you go in for, radiation, right? You're routinely opting in, even if we don't always think about it that way, to keep going. So it's months of ongoing adherence. So then in a working paper that actually hopefully me and my co-author Tanya Stivers publish soon, we explored what happens when patients are in the middle of treatment. Do we see moral language come up, and like, what's it looking like in the middle of treatment when patients are suffering side effects? So, and some even are directly questioning whether to continue, but others are more implicit, like, I feel terrible, like I'm not sleeping, just like a laundry list of side effects. And so the question is, how do physicians advocate for why that this treatment is important in light of those complaints? And so we found 4 practices that we argue invoke the morality of perseverance, and this occurs in 22 encounters. And so if you actually add up, and I'm not really this is not really quantitative talk, but if you add up 23 and 22, that's 45. And then we've got 51 total encounters with the recommendation. So that's a plurality of the recommendations. Total recommendations involve some morally charged language. So that's notable too, even though I didn't really clearly outline that here. So first is framing treatment as a necessary struggle. And again, these frequencies that I'm about to show are really more just so you could see like the distribution, but these frequencies showed up sometime, like some practices showed up in more than one visit, so they're not going to add up to 22. So framing treatment as a necessary struggle, like you've gotten past the worst part of chemotherapy, implies you should keep going because you've already invested so much, right? It makes stopping potentially seem like a waste of effort because you've gotten through the hard part. So second, we identify as normalizing and minimizing suffering. So direct quotes, "This is par for the course. I know it's frustrating. Treat suffering as expected and therefore manageable." While it's only 4 or 5 seconds, right, talking about radiation, makes concerns about it seem potentially disproportionate. Like if it's only 4 or 5 seconds, it's no big deal. And the patient just was concerned about the scarring actually, but the doctor's trying to respond and say, well, but it's so quick, like it's not going to impede your life in other ways. Third is praising patients for persevering. Direct quotes, "You're a rock star," or "I count on you for pushing through." This is persuasive, we argue, because it reinforces enduring the behavior of a good patient. Stopping would mean potentially letting your doctor down, which is a potential implication of this, or just failing to live up to the identity that they've cast you as, right? Like you're such a rock star for getting through that infusion. And finally, always offering, or I shouldn't say always, regularly offering additional treatment solutions. So one example, which is my favorite, which I provided here, there are 11 more, is there's no evidence this is great, but at least you'd be doing something. And this is because the patient has complained that his current treatment is not working. He knows the treatment's not working because that was part of the visit. He is also complaining about the side effects, wants to do something, but isn't sure what to do. He's miserable from the side effects. He's has gynecomastia. He's exhausted. He just feels like he's losing his manhood and he just wants his life back. So the provider recommends an additional sort of clinical trial and says that there's no evidence this is the next best thing since sliced bread, but at least you'd be doing something, right? And this frames as something inherently better than doing nothing, right? Which can imply that stopping treatment is the equivalent to giving up rather than a legitimate choice. So with the time we've got left, so I can leave a few minutes for questions, let me connect these findings back to where we started at the very beginning, the paradox of end-of-life care. So across the entire cancer journey, from diagnosis through mid-course treatment to late-stage disease, treatment is framed with moral weight in these data. And these language patterns aren't just about individual decisions. They are, but not just. They create broader consequences for how patients understand their options. This moral framing of aggressive treatment might help explain why comfort-focused care gets delayed. If treatment is always the morally correct path and framed as such, comfort care can't really be introduced until that moral framework breaks down, which only happens usually after we've tried everything else. The moral construction of treatment as fighting makes it difficult too to introduce comfort care without it sounding like a defeat. And instead, when comfort care is finally mentioned, it can carry the moral weight of giving up. It can signal like we're out of options rather than being presented as a valued form of care. And those are subtle differences because you might very well be out of options, but framing it as we're out of options versus framing it as, you know, this is the next step, like this is where we're at, can signal that it's coded as a surrender. So what do we do with this? Let me be really, really clear about the potential tension that this creates. Okay. So I think first, analyzing these moment-to-moment conversations is really a really important methodology for understanding larger ethical dilemmas in medicine more broadly. And let me be really clear about this. Clinicians are using these strategies because they genuinely believe that these treatments offer patients the best chance at a longer life. I'm not here to dispute that. But the consequence of such morally charged language might be that it inadvertently constrains patient autonomy. Now, I want to acknowledge that this approach also has benefits, though, right? Moral language can motivate patients to pursue beneficial treatments they might otherwise avoid. I remember I was at an ethics lecture here like 5 years ago, and an ethicist came and shared a case about a stage 1 or stage 2 breast cancer patient, and the mastectomy was the recommended treatment course, and she said no because I really value my breasts and I'm 55 and my husband values them and like it's my quality of life, I will not do this. And you know, he asked the audience like, what do you do? And like there was, you know, people were in an uproar. They were like, I would like not let, some people were like, I wouldn't let her leave until like she, you know, was so clear. And his question was like, but are you infringing on her autonomy? Like she's told you that like this is the most important thing to her. And there was a range of responses, but it was actually a really heated, you know, discussion. And so I acknowledge that there's a tension here. And there was a lot of moral language in that discussion in the auditorium, like moral language can motivate patients to pursue beneficial treatments they might otherwise avoid. But the tension is that patients deserve both things, right? They deserve expert guidance from physicians or clinicians who know what works. And they also deserve genuine choice to make decisions that align with their values. And so the question I want to leave you with is this, like, how do we honor both of these principles without sacrificing either one? And is that even a possibility? I don't know. And I don't have easy answers. But I think recognizing some of these patterns is the first step towards navigating them a little bit more thoughtfully. Thank you for your time, and I'm happy to take some questions.